Hey everyone. So this is the lecture on the GI. I'm going to break it up into small videos for you guys. So Gerd, let's just take a look at this picture. I know we spoke about it, but take a look at this picture here. We've got Gerd, so an increase in gastric secretions. And normally this lower esophageal sphincter is closed. It opens as food comes down into the stomach, and then it closes very tightly so that the acid cannot go up into the esophagus. We don't want the acid to go up into the esophagus because if it does, it can cause esophageal erosion. So this is a section here that's showing GERD where the lower esophageal sphincter is not completely closed. So it's not closed tight, it's weak. It could be from increased pressure in the abdominal area, maybe from obesity, lots of different things, infection, liver disease, increased pressure. Or it could just simply be a deficit in the lower esophageal sphincter itself. What I want you to think about as well is that GERD is not alone. So if we take a look at this sphincter right here and we kind of draw a line across it, we can kind of pretend that that is the diaphragm. And when the stomach has extra pressure, or pressure is being placed on the stomach, this stomach can actually go through a weakened area of the diaphragm right here, okay? So this would go above the diaphragm, and that is considered a hiatal hernia. Most of the time, people can just, can push the hiatal hernia back down through the weakened muscle of the diaphragm. But when someone also has GERD, that pocket, let's take a look up here. Let's say this is the hiatal hernia right here. Gastric acid can be stored in here and then also go up into the esophagus. So a problem with the acid going up into the esophagus is, like I said, it causes erosion of the esophagus. And the lining of the stomach, the mucus lining of the esophagus obviously doesn't like that either. And so what it can do is, obviously it goes through that inflammation process, scarring, fibrotic tissue. And as it starts to scar, the esophageal itself starts to narrow. It becomes hardened, and so strictures can occur, and then bleeding can occur as well, which is very bad, and that would be an upper GI bleed. What the body also does, though, is to help protect the esophagus lining. It uses something called Barrett's epithelium, so it replaces the nice normal lining, and it replaces it with Barrett's epithelium tissue to protect the tissue. However, the problem with that is that Barrett's epithelium is pre-malignant. So it is a pre-malignant correction that the body does. So what we need to do is decrease pressure. That could be through your educating patient on weight loss. But, you know, in a lot of cases, there's not necessarily a reason for this or something that we cannot really correct. So our job is, as far as GERD is concerned, is to teach them about low acid foods, as you'll learn in med-surg, but also take a look at the medications that would be normally prescribed for this patient by the physician. Now, one is called a proton pump inhibitor, very, very common. They can take it PO or IV push in the hospital. The most common one is pantoprazole right here, or Protonix. Another one is the histamine 2 antagonist blockers, and those would be famotidine, cimetidine, and ranitidine. And all of these in their own way, which you'll read up on the med sheet, decreases the acid production or slows the acid production itself. Okay. So next, let's talk about peptic ulcer disease. Let me just make this picture bigger for a second. Okay, not too bad. This is the diaphragm. They're showing you the diaphragm right here. So remember what I was saying about GERD. If the diaphragm is weak here and the stomach starts to go up through the diaphragm, then that would be a hiatal hernia, and acid can stay in there. So peptic ulcer disease is different. It is, one second here, it is actually caused by two primary ways, one being very primary, which is the H. pylori bacteria. Okay, so we have H. pylori bacteria, and the other is NSAIDs. So H. pylori is a bacteria that really damages the inside mucosal of the stomach. And when we think of NSAIDs, NSAIDs is a non-steroidal anti-inflammatory, and as we know, NSAIDs have a side effect of GI bleed, and that's because it can adhere to the stomach wall and start to wear away at the stomach wall and take that take the protective layer of prostaglandins out of the stomach area. And so this is the mucosa right here of the stomach. And so if it takes the prostaglandins that actually protect the stomach, then it has a direct route to the other layers of the stomach lining. So ulcers are formed. These are different ulcers: esophageal, duodenum, and gastric ulcers. Gastric and duodenum are the most common, and because it destroys the lining, this is one where the erosion will actually go all the way through the layers of the mucosa of the GI tract in the stomach. So that is the difference really between this GERD, which is just eroding some of the esophageal and causing this Barrett's epithelium, whereas peptic ulcers actually kind of drill down, if not taken care of, drill down through the lining of the stomach. So like I said, H. pylori is the primary cause of this. You'll get a lot of GI bleeds with peptic ulcer diseases, and that's why we ward off patients from taking NSAIDs and other medications that deteriorate the stomach lining, because it's just going to exacerbate their peptic ulcer disease. So there's that break in the protective barrier, mucosal injury, and that, like I said, from the lack of prostaglandins or the H. pylori bacteria. With that injury, again, inflammation, so we have a histamine release, and then that hydrochloric acid, which is the gastric acid, injures the lining of the stomach, causing edema, bleeding, and erosion of the lining wall. So if the erosion can go through this lining wall, what can happen then is the GI tract secretions can actually get out into the peritoneal cavity. And so with that actually comes peritonitis and then sepsis. So these are things that you need to watch for with your patients with peptic ulcer disease. Let's see here, hold on. Oops. Oh, no, I thought I had it the wrong way. There we go. A little wobbly, but it'll do. So let's take a look at these protective layers. So the mucosal layer right here, actually has, it protects itself. So it has the bicarb in it to protect the lining. It has those prostaglandins to regulate inflammation and inhibit acid secretion. It does this in a really nice balance. And then the parietal cells actually release that hydrochloric acid. So with the erosion, we can have GI bleed and peritonitis, like I just said. So our medications for this are antacids, because we want to decrease the acid in the lining so that it is not going to either further erode or further damage the ulcer. So if they have an ulcer, we want to try and protect it. So we want to decrease the antacids. We want to give them the histamine 2 antagonist blockers, so block that histamine so that there's not as much irritation and inflammation. and this spreadsheet will show you the mucosal barriers. One of them is sucrafate, and it coats the inside of the lining, of the mucosal lining. And actually sucrafate actually really enjoys sitting on top of these ulcers, so it's a really good protectant for the ulcers. Our proton pump inhibitors, like we just mentioned, we also have, to decrease the acid, our prostaglandin analog. So we can add, you see how prostaglandins is a protectant, it regulates inflammation. We can actually give prostaglandin supplementary. And then for this, because we have H. pylori, we're going to want to give them the antibiotics for the actual bacteria itself. So they'll be tested for H. pylori, and if it comes back, then they will have the antibiotics given to them.